So good morning. We're going to start out this day looking at a profile of who has insurance coverage in the United States and what factors lead to you having insurance or not having insurance. And then we're going to just give a quick overview of the business model of the private health insurance industry. Let me see if we can. Okay, so we have in 2021 at least just over 90% of our population has some form of insurance, and just over half are in a group plan, which one generally gets through one's job. So, for example, a lot of you will end up working for, say, a hospital, and you will get group health insurance through that hospital. You'll pay a portion of the premium most likely, and you'll very likely have co-pays. And those and deductibles and co-pays, and those have been gradually growing over time. The next one is non-group. That's 13.7. If we had done this before Obamacare, it would have been around 5 or 6%. So about 6 or 7% of the population is purchasing a plan through what's been called the exchange or the marketplace, which was legislated through Obamacare and implemented in 2014. And it allowed you to buy a health insurance policy, and that the premiums were going to be subsidized through Obamacare. And for those of you following current events, an important element of this big, beautiful bill that's being voted on maybe even this week, is to greatly decrease the size of the subsidy, which will result in many fewer people going ahead and purchasing policies on that exchange. In addition, they're decreasing the window of opportunity you have to get on it each year. There's an enrollment period, and it's proposed to shrink that, I think, to only a few weeks or maybe a month. But anyway, so that would be shrunk. And the estimate in the state of Vermont, when they estimated what this big, beautiful bill, how it would impact people, we lose 30,000 people from what they're planning to do to Medicaid, but 15,000 more because fewer people will end up with coverage through the exchange. So that's the impact on Vermont, and it's not different from the rest of the country. Then the Medicare entails about 18 or 19% of the 19% of the population is covered through Medicare. It's been up. It's now, so it's up to 19%. That's about 65 million people currently. And then Medicaid and CHIP, which is now up to 79 million just in the last 4 years. That's about 22% of the population currently. And then the military, TRICARE for active military and VA for retired military, that's around 5% of the population. And some of the VA people are also on Medicare. And then uninsured population is around 8.6%, which will probably go up to, it's probably going to add on another 13 million between the exchange dropouts and the Medicaid, people who lose Medicaid, if this bill passes. Anyway, so it's around 10% of the population has no insurance, so it'll end up around 39 or 40 million if the legislation passes, and probably stay around 28 million if it doesn't. So
I just want to note, Dr. Malek, this is during the Medicaid expansion, during the pandemic Medicaid expansion, correct? So the numbers might be a little bit off, a little bit different today.
worse now.
Yeah,
Yeah, the last estimate I've seen though is still around 78 or 79 million people insured through Medicaid. It's 22% of the population. And the effect that overcame what you're talking about is ever worsening income inequality in the country.
Yeah, I thought about doing mornings at the gym.
That more and more people are qualifying for Medicaid because they're poor.
I see. So even though it's not expanded, more people still qualify.
Anyway, okay, so among full-time year-round workers and the other members of those families, you have 85 or 87, a large percentage of people, 87%, have private coverage. And this is on the left, and it's nonetheless 9% or so uninsured, and another 8% with public coverage, which is basically Medicaid. So what you're seeing here is that even full-time employed workers, that 16 or 17% are not, or I'm sorry, 14% are not getting covered through work, and a little less than half of those people qualify for Medicaid. So that's sort of another way to subsidize that employer, that they're not providing. That's the deal in the United States, that you go to work full time and you get coverage through your workplace. But these employers are kind of I almost use the word dumping, but they're basically saying to their employees, good luck, we hope you get some coverage, and the taxpayers are going to pay for it while I'm presumably making a profit from my business. So, but that was the deal, the great bargain in the United States, dating from the 1940s, that your employer was expected to provide coverage. Now, on the right, for less than full-time workers, a much higher percentage of them don't have coverage. Only 2/3 are getting their coverage through their workplace. And that percentage that's been steadily dropping. And, again, a little over half of those are covered through Medicaid, public coverage. And these jobs typically are lower wage, and which is why a larger portion of this group are getting coverage through Medicaid, and they're not working full time. So just to look at different occupations. So now we're back to full-time workers. And for those like a doctor or a dentist who's in a professional occupation, or a lawyer, they're about 90% likely to have coverage through work. But if you look at the 5 occupations at the bottom 5 bars, sales and related occupations, transportation and material moving, these are truckers and other people who move things around. Service occupations, this might be somebody employed at a gas station or Walmart or something like that, who may or may not have coverage. And here this is telling you what percent do. And then construction and extraction, and then farming, fishing, and forestry. So these are jobs where there's a good likelihood you're not getting coverage through your employment. And these are not rare types of jobs. This is a whole lot of people. So these very common jobs, which in general are lower wage than the jobs at the top, which included professionals, management, administrative, and then factory jobs. These bottom 5 bars are really common jobs, and so that they're so much less likely to get coverage, suggests what we're facing in the United States, that we have a situation where in many types of employments, a gas station owner may not have enough money to provide coverage, and so a lot of the people have to go bare. They're making too much money to qualify for Medicaid. And some of them may elect to get on the the Obamacare exchanges. But if you talk to patients about insurance, many of them will say they wish they had more insurance choices. All these policies are too expensive. And people who watch, sources of information on the political right will undoubtedly blame the government. too much regulation at the state level or whatever. It's someone's fault, but there's very little discussion doing what you're going to do, which is comparing our circumstance to other countries. So let's just move on to the section where we're going to talk about how health insurance companies, what their business model looks like. And so here's in general, if you work at a health insurance company, you probably have one of these jobs, and or have your money, the expenditures of money at the insurance company are going to these various things. First of all, they sign up people who want insurance, and they're providing that insurance. So there are a certain group of people at the insurance company who are simply paying the bills that doctors are sending in. So one of your customers goes to the doctor, and the doctor says, "Oh, you have insurance through Blue Cross." And then they send a bill to Blue Cross, electronically most likely. And Blue Cross has to have employees who make sure that that bill gets paid. Then there are people who look at utilization, and does there seem to be a aberrancy in utilization? Is one hospital doing a million more hip replacements than some other hospital? So they'll look at utilization and see if there's any outliers or a suggestion of fraud. And so a certain number of people will be employed to do that. Then there's people in provider relations. At the insurance company, they want to have enough doctors and hospitals on their panel so that people who live in a certain community will be able to get the care they need. And in general, what's going on here is that the insurance company goes to, say, a local hospital. Say there's 3 hospitals in a small city, and the insurance company has a choice. They could negotiate with all 3 hospitals and come up with an agree upon a rate that they're going to pay the hospital for certain, variety of procedures, the whole gamut. And there's usually a whole proposal, and then they'll ask for a percentage off that fee scale, especially if they're going to prevent one or even 2 of the 3 hospitals from being on their panel. So they're going to give that provider a volume discount. They say to a hospital, "We're going to send all our patients to you preferentially, and if patients want to use the other 2 hospitals, their copay is going to be higher, or something. You're going to be sort of out of our preferred network." So this is provider relations, is setting up networks, negotiating with doctors in hospitals, dealing with complaints from those providers. And this will involve, a fair number of employees too. And then there's quality monitoring, and we kind of talked about this the other day, where insurance companies, even though they're not treating a single patient, there's monitoring of quality, because if they're denying coverage for certain things, which nowadays most of them do, this is prior authorization or refusal to even pay a hospital at all. Since we don't like that in general, the patients don't, when they have to be able to justify what they're doing. So there's measurements of quality to say, well, you may not like the fact that we're denying payment for your hospital care, but at least all of our patients are getting COVID and tetanus shots, and our kids are getting lead screening. So this is the kind of stuff the conversations that go on. There's a set of quality measures, and they all try to look good on those very limited array of measures. Then there's people who work on marketing and advertising, because they want to get businesses in the community to be interested in their policy. So these are people who might go around to local businesses and, give them a discount, agree on some rate, and, sell their policy. It used to be that, many years ago, that there would be a lot of marketing to individuals. and there, in some states, for the exchanges, you actually do have a choice. The one area where there's actually a choice left is in Medicare, and you've seen, those of you who watch commercials on, cable TV, you'll see a lot of Medicare Advantage commercials, because the patients actually are making choices among those insurance companies. And then there's a certain number of employees who are lobbyists. Then there's money for the CEO, there's the management suite. And so a certain amount of money is going to pay the CEO and the other managers. And then all insurance companies have to devote a certain amount of money to a fund balance. So in other words, each year the insurance company operates, they would like to generate, if you're in the not-for-profit sector, it's called a fund balance or retained earnings. In the for-profit sector, it's called profit. And you want to have a fund balance because you might have a bad year. When you go into a year, you don't know if there's going to be an epidemic or something going on that could increase the number, the utilization and the demands on your funds. During the COVID pandemic, there was actually less care provided, but that's not necessarily how it would be with every pandemic. It probably would be that way, especially with respiratory ones. But other things could happen to the country. There could be, more conflict, military conflict, or something that would end up with more injuries and more people needing care. So you don't really know at the beginning of the year exactly how things are going to go. And so, the introduction of obesity drugs was a huge event. And if insurance companies were going to cover those drugs, their costs were going to go up. And in fact, that happened. And many insurance companies actually are having trouble, those who have decided to cover those. And then in the years following the COVID pandemic, when people started getting out of the house, there was a whole lot of catch-up care to go to that needed to be provided. So when people started getting the colonoscopy screening and the elective surgery that had gotten delayed, during over a year of the pandemic, those insurance companies started to have more trouble, with their getting their funds to balance. So you need to have extra funds, and there's a certain percentage that's considered the basic amount. And if you start depleting your retained earnings and your fund balance, then you're considered a risky insurance company, and you may not be able to borrow, you may lose your credit rating, and other bad things can happen. Get into trouble with a state insurance regulator. So then there's additional expenses of for-profit insurance companies like Cigna and Aetna and United Healthcare. They have to devote a certain amount of money to profit, and they still need a fund balance, so they can't give it all away as profit. So they still have a fund balance they have to maintain. And they often have a paid board of directors that oversees the managers, the management suite. And then there's investors, and investors expect to receive dividend or see the company's stock grow. And so those are factors in that you have to devote a certain amount of money for. And then investor relations, you have to send, notices to your investors and have an annual meeting. That's where the fellow from United Healthcare got shot last December. They were holding a meeting in a ritzy hotel on Manhattan, New York City. So, that was an expensive meeting to hold. And now they're going to be spending a lot more money on security, whatever. So fees related to public trading. So these are all costs for a for-profit insurance companies have to bear. So you may want to go back to this list if you're looking at which of these costs would still have to happen in a single payer system, where basically there's one public insurer or provider of coverage. And you'll find that provider relations, the expenditures on provider relations are minimal. There will be attention paid to utilization, but not merely for the sake of making profit and detecting fraud, but also to look at improving the public health. So attention will be paid if there's many more visits for respiratory illness and you're encompassing an entire population, then you really have good data that there may be some sort of epidemic of respiratory disease. So looking at your utilization in a single payer system has tremendous public health potential. Whereas in an insurance company, if there actually were 10 insurance companies in the community, they may not know that much more. You're not reflecting the entire population, so the data are somewhat less useful in public health terms. And they're primarily looking at utilization related to their bottom line. And then in a single payer system, marketing and advertising, that wouldn't be necessary. You'd be putting out public health messages, but obviously you want to do that, but you're not looking at it from the point of view of profit. And then lobbying you're not going to do that. How much money your CEOs are going to get paid? Well, in the public sector, managers are paid a whole lot less than in the private sector. And then the issue of retained earnings in the US, we just throw it on the national debt. The word of the United States that they're going to pay a debt is supposed to be sacrosanct. This is always discussed in our Congress, but anyway, but here in the current system, you have multiple insurance companies, each of them having to accumulate a whole lot of money by charging their ratepayers enough to maintain that balance, that fund balance. And then all of this would just go away. The expenditures related to a for-profit system and dealing with investors and all that. So if you were in an insurance company and you were the CEO, when you look at these various departments that we just talked about, which of them would you invest more in if you wanted to make a profit, ensure your profit? And which of them would you have less motivation to spend more money on? Like, let's go back and look at them. I mean, these are kind of obvious. You have to generate money, so you have to deal with your investors if you're in a for-profit system. But if you were a CEO of an insurance company, which of these could you cut if you were having financial trouble? Any thoughts on that?
Maybe quality monitoring?
You could try to spend less money on that. There may be requirements to submit a certain amount of data, but yeah, you could look there. Probably not too many employees in that department, but anyway, yeah, sure. So what else?
I know paying medical costs usually is a big area that they'll focus on in their earning reports of like how many prior authorizations they're going to do and what percentage of people fight those or whatever.
Okay, so you've gotten into the first two on that list. The prior authorization would go into kind of utilization. How are you picking at your utilization? And the issue of utilization has been analyzed. And there was a year when United Healthcare said, we're not going to do it. We're going to spend less money on prior authorization. And they got rid of a whole bunch of employees. This was maybe 15 or 20 years ago. And they did a little worse because they deny so many claims and deny so many prior authorization requests. But there are employees in that department, and it was a consideration that they could just sort of let people go to the doctor and not bother them and see how much difference it actually makes. Because remember, when we looked at that in Medicare, they were denying 6% of prior authorization. So, they were approving 94%, and the whole thing required some employees to do the 100% to get those 6% denied. So, this is a question, and you could take a chance at cutting that department and see how it goes. So now it, could be done. United Healthcare went back to, they decided finally they did lose money when they stopped doing it. So they went back to picking at doctors and not letting, a lot of procedures be covered. What about now the first one you said, which is just having fewer employees who are paying bills? So if that leads to a delay in payment to doctors, what are the implications of that? This is called the accounts payable. You owe a certain amount of money to people who, to these practices in the hospitals.
You get an interest-free loan.
Yes, don't laugh. That's exactly right. So many of them intentionally wait 3 months to pay bills, and they earn interest on their accounts payable on the people they owe. This is exactly right. And this is an important strategy because it gets them a little extra money from if they had put it in an investment, there's a certain return on the investment. For those 3 months, they're not paying the bill. And so they then have a little extra money. And, if they're getting away with having fewer employees in the department, then all the better. They have less expenditures. And I have to say that in Canada and countries that do have single payer systems, this is one area they generally don't skimp on. Like, I have friends who work in Canada. One of the advantages of living in Vermont, we have, more connection, and they get paid promptly. They get paid promptly, and this is generally true that this is not an area that single payer systems look at. But in this country, it varies by insurance company, but it's an opportunity to earn some interest. So marketing and advertising, what do you think of that one?
Seems like if they cut costs for marketing, and conversely, if they kept putting money into marketing and advertising, it's something that could bring them back more money, as opposed to something like paying medical costs. Whatever they cut from there is just a total recoup, essentially.
Yeah. So it could go either way. It may not go well. That's what you're saying. They may need to do that.
Yeah.
And how about lobbying? Do you spend much less money on lobbying? Nobody's saying yes. Well, let me just tell you, you never stop lobbying if you're in the healthcare business. You lobby every day. You lobby hard. And I swear every expenditure they make, it's worth it. Because they're so dependent on the status quo kind of being supported by the political sector of the United States. Lobbying will never be cut. And I'm sort of including campaign contributions in that category of efforts to influence government policy. Is never cut, always a good expense. And then CEO compensation, it's not going to amount to that much money. So, but I do resent it nonetheless as a ratepayer when they're paid in the millions. And then retainer earnings, I think we already talked about that. If it gets too low, you'll get in trouble with the insurance, regulators of your state, and you could be downgraded, and that might get you bad publicity. So that's problematic. And then all of this, so companies do pay less profit when they have a bad quarter or a bad year. And, then they may get less money and they may get fewer investors. So there's limits to what a for-profit company, how much they can cut there. Anyway, so this is the U.S. House of Representatives. And when you're looking at the distribution of health costs, that body of the US Congress seems to think that this is how health costs are distributed. This is your friendly old bell curve. And if you apply this to healthcare costs, what it would mean. So I told you that the average amount of money that Medicare beneficiaries cost the government just a couple of years ago is $15,400 or something like that. So what that would mean was that most of the people in Medicare cost around $15,000. Then there's, a lot of people, like fall between 14 and 16. Then there's maybe fewer who are out at 20,000 or 25,000 and, fewer that don't cost anything. So does this curve apply to reality? Zach is shaking his head no. Anyone else think this curve applies? All right, well, that group seems to have often generate policy that one would make you think it does, but in fact, it doesn't. And the curve that actually applies, which these guys in the executive suite and insurance company, they all know the right curve. They know what's going on. They don't think it's a bell curve. They know it's that curve, which we already looked at. So the insurance company has 10 or 20% of people, are the bars on the right, who cost the most. That's on the right where it says 10, that's the 10% of the population that are generating 62% of costs for the particular population. And so and this applies to every population you can look at. And some are more skewed than others. For the elderly, this is the curve that applies to the elderly. If you looked at children under the age of 1, the curve is even more extreme because the preemies and the kids who are really expensive cost so much money, and a lot of the other kids just don't cost much. And then if you go to the second year of life, the curves get pretty extreme too. Anyway, so this will be the curve in general, and insurance companies are always aware of who their insured population is, and they're trying to figure out ways to contend with these people who are expensive and get more of the people in categories, 1 through 6 or 7, who are not costing them a lot of money. And finding ways to drop the people who cost a lot is sometimes referred to as lemon dropping. And finding more of the people on the left side is called cherry picking, where you, as an insurance company executive, that you're gonna make a whole lot of money off those people who are healthy. So you try to get more of them into your plan, and it can be called cherry picking. Anyway, so what are the most effective strategies to improve plan performance? And this is kind of what we've been discussing, and here are some of them. Selective marketing, pick out people who are healthy to insure. Rescission is where you just simply cancel a policy of somebody who's sick. This is prohibited in some states, but not every state. That may seem appalling to you. You just had a bad year. You got diagnosed with, say, breast cancer or something that's kind of expensive, or lupus, who knows. And the next year, the company just says, okay, you're out. We're not going to write your policy. So this goes on in the individual market. And groups, it's more of a problem. I will tell you that many companies are now doing something called becoming self-insured. That means that, so at Springfield Hospital, where I worked a few years ago, like many other companies, they decided if we just get Blue Cross in Vermont, our premiums are higher than what we think we can do just insuring our own employees. We think our employees are healthier than the general population of people who are going to end up in Vermont's Blue Cross plan. So we're going to self-insure. And unlike Walmart, which is a huge company and can afford to self-insure because the risks balance, Springfield Hospital only had 750 employees, and bad things happened, and they got into trouble. They actually went bankrupt, and part of the reason was because they had some, you know, it only took 4 or 5 really expensive employees and family members of employees, and they got into trouble. So you can self-insure. Anyway, so you're uh you can't, the Blue Cross could have cut off Springfield Hospital when they got expensive, but Springfield Hospital had self-insured, so that didn't happen. But Springfield Hospital itself got in trouble. So those, when things get bad, you know, there may be reactions that are getting less people coverage or causing businesses to get in trouble. Now, by the way, this notion of when General Motors, in some years or most years, when they look at their expenses, they're spending more money on healthcare than they are on steel or rubber. And in an ideal healthcare system, country with a high functioning healthcare system, you would want an auto manufacturer to succeed if they're producing the best car at the best price, not because they've figured out a way to spend less money on getting their employees covered. So I just keep that in mind, that now companies' performance are partially based on this other thing, which is not their core business. And just something to think about is another manifestation of a dysfunctional healthcare system. So they could harass doctors with prior authorization, delay expensive care, rehab stays. So chronically deconditioned and chronically ill people are often very weak. If they get pneumonia, they may not be strong enough to go back home. They could go to rehab, which is usually done in nursing homes. And so a major strategy of the Medicare insurance companies, the Medicare Advantage plans, is to block people from going into rehab with any number of delay tactics. This is not done occasionally. This has almost become routine, that you expect a delay of 2, 3, 4 days with each hospitalization. So, and we're going to talk more about benefit design a little later. So here's more on claim denials. One of them denying 49% of claims. So anyway, variability in what percentage of claims are going to get denied. And finally, doctors don't tend to learn that much about how health insurance companies operate and what they're up to. And it's because they're busy reading the New England Journal and, you know, the Annals of Internal Medicine and the, you know, Annals of Surgery, and they're not reading the business press, which is the way it ought to be. You should be reading the New England Journal and not have to read New York Times to know what's going on in our healthcare system. But this is what goes on if you actually want to know what's really going on. And this, we wouldn't be able to do any teaching in this internship if we weren't looking at these other sources. And, you know, only occasionally you'll get a good review article in the New England Journal or a regular medical journal, but, you know, it's just not there and you don't get the real story. So it turns out that 5 insurance companies control much of the market, even though there are, you know, 900 plus insurance companies. These are, you've heard of them: United Healthcare, Aetna, Cigna, Humana. Anyway, so we're going to get back to this. Let's take a 5-minute break until 9:57, and we'll then get back and talk about Aetna and what it did in 2002. Okay, so during this century, the first 25 years, so far the biggest event has been the Obamacare legislation. And I guess second place might be the drug plan, the drug benefit in Medicare Part D, 2003. But I have to say, I think this one might be third place. Obviously, the current Trump legislation would be a big one. In 2002, Aetna had a bad year. They, or 2001, they had a bad year. And here's a report from the New York Times business section in August of 2002. that Aetna reported a 10-fold jump in profits in the second quarter yesterday as it struggled to recover from a money-losing spiral, began to show signs of success. And so notice the company earned $108.2 million or 70 cents a share, compared with only $10.6 million or 7 cents a share just 1 year earlier. So a 10-fold increase in profit. So notice the next sentence, revenue fell to 5.06 billion, and it had been at $6.5 billion. So let's just think about that. Their profit increased tenfold, but their revenue didn't increase tenfold. It actually dropped. In other words, if you were producing radios or some object, you might have a tenfold increase in profit if you sold 10 times more, or if you sold a lot more despite, you could try raising the price, but you might lose your customers. So probably you'd have to increase your market and sell 10 times more radios. But here you have revenue falling by about, I don't know, whatever, 30%, 15 or 20 or 30%. And yet they're making more profit as they're shedding unprofitable business. Their first profitable quarter after a string of losses. So here's what they did. They turned away unprofitable business. And they cut the number of people they insure from 22 million back in 1998 when they started losing money. And now they were all the way down to 4.4 million people. And they're even trying to go down to about 13.7 million by the end of the year. So Aetna is, so they were getting rid of businesses that they had been covering, which were expensive, costing them a lot of money. Small businesses that had high expenses, like Springfield Hospital had for those years. Aetna was happy to see some customers go. The companies have been heavy users of medical services, and they've been costing us money. If you don't raise your prices with surgical precision, so what they were doing was they were taking these companies that were costing them a lot and drastically raising their rates, tripling, quadrupling their rates, with the goal that they would just not buy the coverage. And they didn't. And the trick is to not drive away the profitable customers. So you use surgical precision, or you might chase away your healthy customers and be left with the sicker people, God forbid. So clearly they're on a methodical road to improvement. And we're not interested in being the largest. We're just interested in being the best and the most profitable. So now, if you think about the 8 million people who are losing their coverage, they may be in small businesses. When those 8 million people lost their coverage through Aetna, if you were Cigna or another insurance company, are you running to pick those people up? No, you're not. And so this is significant. Those people, businesses and their employees lost their coverage, and many of them couldn't get coverage back very easily. So this is one of the consequences of having a system that's a for-profit free-for-all. Now, if you were a local nonprofit Blue Cross plan in the community, would you want those businesses? No, you wouldn't. So Blue Cross, many years ago, maybe 30 or 40 years ago, there was an interaction, a discussion about whether Blue Cross was going to continue being required to take every single business in the community, or whether they could do instead of that was called community rating, where they take all comers, or they could use experience rating, where they look at the experience of a business that wants their insurance, and they could reject them or charge much more using experience rating. And they had to, in a competitive market, they had to be allowed to use experience rating. And so their lobbyists, had that victory, and it was necessary, however, for them to, remain functional. So obviously their CEOs are going to do well. They didn't trim that expense. It's not surprising. And so another impact of this insurance system is that the U.S. has had growth in administrators. And let's just look at this graph. The yellow bar at the bottom is the growth of physicians. In 1970, there were 300,000, or 300,000 physicians in the country. And the yellow bar shows that growth, that they had grown all the way to 880,000, or moving toward 1 million doctors by 2017. But during that same period, the percentage growth of administrators just dwarfed the number of doctors. So the yellow curve actually is increasing, but you can see the powder blue curve really, really picked up when the insurance companies started becoming more and more intrusive. And that was the beginning of the managed care era in the 1990s. That was the heyday of it. But what's important is that even though we supposedly were ending that, we never got rid of all those administrators. That insurance companies still do all that stuff, that they basically still do managed care. And one final point on the private insurance company is Medicare Advantage is much more profitable. And I'm sorry this slide didn't come through very well, but the 4 bars are the individual market. They can expect $745 of net revenue. The group market, which is the big market of private, insurance company, private businesses providing coverage, that's $689 per employee. $768 for the Medicaid managed care, and then $1,730, more than double the expected profit when they were insuring people through Medicare, which is the Medicare Advantage system. So insurance companies have been flocking to this market because they're being overpaid, which is what James Waters' talk was about the other day. That through legal means and through, quote, cheating, making their covered population appear to be sicker than they actually are, through upcoding, their Medicare Advantage, Medicare managed care is much more profitable per person. And all of this, what's going on within the federal government, if DOJ wanted to save money in the healthcare system, that would be a good place to go. And there's been talk of doing it in the Trump administration, but we'll see what actually happens at the end of the day. So anyway, so that's sort of the end of what I have on private insurance companies. And we're going to move on to questions. And when we're done with questions, I might be able to get started on the cost control stuff, because kind of a big topic. So anyway, so by the way, when I heard the rhetoric about government, that there's way too many government employees, you can just fire many of them, that it's heavily bureaucratic, I have to tell you that I thought of this graph, and I was thinking, oh, you're looking for excessive number of administrative employees that aren't doing much that's to the benefit of the public good. Well, you could look here too and think about this. But anyway, no, it's only government employees that have been losing their employment. Anyway, so Let me get out of this. Any questions?
Yeah, I just wanted to clarify with the case of Aetna in 2002 when they're dropping profitable businesses. Is this like providers, so like hospitals that are mostly seeing um um very sick and like costly patients? Is this individuals with diagnoses that, or are these employers that have a more sick patient population? Or is it like a combination of all of those? I'm just wondering how they did that.
Well, can I stop you for a sec? You're kind of breaking up, and I personally didn't hear what you said. And there's a lot of extraneous noise going on in the background, which isn't helping. Eve, can you maybe put your comment in the chat, and we'll go on to Therese?
I don't know if this is something that will be covered in future sessions, but I was wondering if you could elaborate a bit more on like the regulations or the current standards that private healthcare insurance companies have to meet. I don't know if that's too broad of a question.
It's not too broad. It's a very good question. And in general, when a sector is performing in an unhelpful way to society, let's just put it that way, as they're functioning at a point in time, your choices are to do nothing, which is what you'll do if they have a good lobby, and let the dysfunction continue. Your other two choices are to replace them, just get rid of them entirely, like with a single payer system, where you're eliminating health insurance companies. But your third possibility is what you're bringing up, which is you could regulate them in any number of ways. And I was alluding to the fact this morning that they have to have a certain amount of money in a fund balance in case they're facing a bad year. You could try to regulate their prior authorization, activities. Vermont, we just passed a law last year prohibiting prior authorization entirely on primary care doctors. Because we're a small state, the doctors have been relatively more effective in their getting the legislature to do useful things. Also, it's just a more progressive state in general. So we made a little progress. Let me tell you though, even though they did that, that law only applied to people under their jurisdiction, which was the general Blue Cross plan they could regulate, not people who were self-insured. And that self-insured is actually more people than the people who are in a general policy. So self-insured has become very big because most companies think they can do better than the general group of people getting general insurance. So didn't cover them. It did cover Medicaid, but it didn't cover Medicare at all because that's federally regulated. So in other words, the population it applied to was limited to about 40 or 45% of the state. It didn't apply to the military, it didn't apply to postal workers, didn't apply to Walmart with their self-managed plans or all the companies who were self-insuring. So we were left with, the law looked great, but it was not covering that much. So states have some power to regulate insurance companies. If you're going to ask who regulates policies that are self-insured, like Walmart, that's done through federal regulation. And last year, I created some slides about it. I kind of find it difficult to deliver because, first of all, I find it really boring to talk about insurance regulation. And secondly, and it's not my field, so I don't really feel I have that much expertise. And also I've kind of found as I was getting into the regulations, both at the state level for what they regulate and for the federal government for these self-insured plans that they regulate, it was pretty ineffective. They weren't, other than the fund balance, they don't really do that much. It just looked pretty weak. we are trying to have someone from Vermont state government come on, talk a little bit about what state insurance regulators do. And if we do get that person to come, which I think we will, she can maybe start to get at those questions, like what is regulation like? Anyway, so we'll see if we can do that, but I just was unimpressed by, how much it was really going to do. And also the fragmentation where the ones who Vermont's law would cover versus the larger number of people who weren't covered. And it's just kind of complicated and fragmented. Like none of what you do to Walmart is going to be applied to the Medicare population. It's just kind of a mess. If you're really interested, I can try to make that session happen and you could do a Q&A about state regulation. Anyway, I'm sorry I can't do better than that, but anyway, I'll share my slides with you if you want. I created last year. I'll have to look around for them, but you can probably find them. Okay, so anybody in the chat can tell me what E wrote?
I can share what they wrote. They said they were asking about how Aetna was able to legally drop not profitable businesses. Were they increasing premiums on employers with sicker employees? Or were they paying less to hospitals, providers with sicker patient populations, or changing costs to individuals, or a combination?
Yeah, it was number one. They were increasing costs to those businesses. It wasn't that they were going to pay less when they actually had generated claims. And they actually said that in the article that they were charging those businesses a whole lot more to continue getting insurance through Aetna. Nothing illegal there. Any other questions? All right, so let's move on to just the beginnings of cost control. I gotta find, here we go. All right. So let me see if I can get you on here. There we go. Okay, so the causes of high cost, strategies to achieve cost control. But we're going to break at 10:30 and we're just going to get through the basics of cost, just thinking about cost, and then we're going to break at 10:30 and go on to other topic for a while. So whose cost? So when people say health insurance costs too much, it could be that that an employer like GM is having to spend a lot more money on healthcare than they wish they did, more on healthcare than they spend on their inputs like rubber and steel. And so that's a problem for their business because they are trying to provide good coverage to their employees to keep them healthy and happy. It could be high cost to an insurance company where there's more medical claims, so they're having trouble staying afloat. And state and municipal governments are providing insurance coverage, usually private insurance companies, coverage for their employees. So when rates go up in whatever Blue Cross plan or whatever they're paying into, could be Aetna, they're gonna have to raise local taxes. And then for state government, they have both state employees who are probably privately insured, and then they're also going to take care of the Medicaid population. So they've got it in two ways, state government, or it could be that the federal government is spending so much on healthcare that if you care about the federal deficit, personally I do, then the federal government could say, well, we're spending all this money on healthcare, it goes up every year, Medicare program's expensive, Medicaid's expensive, and that is the stated rationale behind the cuts proposed by the Trump administration that there's a lot of waste in our federal programs, we're spending too much money. So we can get rid of waste and things will be better. And then there could be to people. And we know people are saying their premiums are high. Then even when they pay those high premiums, they got these deductibles if they actually try to use the healthcare. They've got copays. So the question is, when you're saying there's too much cost, well, whose cost? So let me just say, so the Obamacare legislation got to decrease the cost to many individuals in the country. But if you looked at the total cost of the system as a whole, the insurance company, it was subsidizing insurance companies, so their costs essentially, their costs they were actually doing better because they were getting more revenue from these additional people that Obamacare were subsidizing to buy their insurance. So they did okay. On the other hand, the federal government was paying for all this, and there was essentially no meaningful cost control in the Obamacare legislation. They expanded Medicaid, which increased government expenditures, and then this other population who's a little wealthier, they're going to start subsidizing those people to buy insurance through the marketplace exchange. So if you look at the Obamacare legislation, the two squares on the left, rectangles on the left, the patients were paying less. Everybody who got added onto Medicaid and benefited from the exchange, but the federal government was paying more. So there's no cost control there, but it sure looked good for the people who got coverage. So always think about who's paying, whose cost is being increased or reduced. And when I advocate for single payer healthcare, it's because I believe that we can have the system cost less as a whole, and we can reduce costs to almost nothing for patients. Businesses would only be paying taxes to fund the system. They would be out of the business of having to somehow control healthcare costs. So those are some of the effects of having a single payer system in those countries that have such a system. That their total cost per person are a lot less, but yet the care is happening. So that's an important thing. And so comparing single payer reform to the Obamacare legislation as an example. So what accounts for the excessive costs in the US? And the two biggest factors are high prices and waste in the US healthcare system. And those two are related. So in the US, we're spending tremendous amounts of money, over $5 trillion now. And we have the highest per capita cost in the world, twice that of the average for the European Union, for the OECD countries. And here's the overall graph. That blue bar in the middle is the average for the OECD countries, which are the developed countries. And then you've got all the other developed countries with generally the countries with single payer systems being lower on the graph with lower costs. And then Belgium, Netherlands, Germany, and Switzerland don't have single payer systems, but they don't have the US system. Switzerland is the most similar to the US, and then they come in second place. So whereas Italy and UK, Ireland and Canada and Sweden all have single payer systems, and France is pretty close. It's a little more complicated. So again, we're number one in expenditures, now approaching 20% of GDP. But our healthcare is no better and often worse. And this is an important graph. So we're going to look at this now and later. So all of that set of graphs, the clump of many colors you see in the middle, they have a certain slope that their health costs are increasing. And then the bar on the line on the right is the US spending much more. And notice that back in 1980, our spending was comparable to the large group of countries on the graph. And we started diverging. And this was the institution of managed care in the United States, whereas the other countries either had single payer systems or they had intense price regulation and controls on prices and essentially dictated government dictating prices. So for example, in Germany and Japan, most of these other countries, the government sets what most of the prices are going to be for health services to everybody, even if there are several insurance companies that are operating in the country. So those countries generally do better, especially the ones, more so the countries with single payer systems. But even the others, you know, they're doing a whole lot better, and they're not. And they look at the United States, and when they look at the United States, they say, well, they're a bizarre outlier, but we still have a problem because our costs are increasing. So in other words, in every one of these countries, this slope is not zero. Yeah, the US slope is higher and costs are increasing faster, but I'm telling you that each one of these countries view this positive slope as a problem. They're going from, you know, maybe 7% of GDP in 1980, and now they're up to around 11 or something like that, 11%. So that's a problem for every country. And they're all doing the best they can with what they're facing, but they all view it as a problem. Also, the US has very high drug costs per capita compared to all the other countries. We're at the end. We're even off the graph where I see it because I got you guys on there. But anyway, our drug costs are very high, and we don't have a system that addresses it. And for individuals, many families lack the assets to pay all this high deductibles and all the cost sharing. And so this is 2013. So let's say that in that year, 80% of the population had accumulated enough wealth to have around that. In other words, 80% of the population have had less than $51,000 of accumulated wealth. And that includes your house. So a whole lot of people don't have a whole lot of wealth. And the other 20% have more. And now if that's up to 60,000 a year, it's still a major issue. Now, a lot of people own houses, but they're paying a mortgage, so they don't yet own the house, you know, the whole house. So there's a certain distance a long way in paying the mortgage. But still the bank technically owns it. So increments in healthcare spending are consistently outstripping other costs. And medical care priced at $1,000 in 2000 is now up to $2,137. So healthcare costs are very poorly controlled in the United States during this century. And so here's other sectors. The energy sector is on here, vehicles, food, they're all on here. And compared to the median of all prices, medical costs and college tuition have been going up the most. And the deregulation started in 1983 of some of these sectors, and this is the result. So here's another demonstration of that all goods, inflation in all goods is the blue line, and medicine is the. So this leads to bankruptcy in many cases, and what they found is about 2/3 of those filing for bankruptcy cite medical bills, illness-related work loss as a cause of their bankruptcy. And no medical cause at all was only 1/3. So these medical bills, especially the cost sharing part of it, not just the premiums, are a big part of this. So insurers raise premiums to make their plan marketable and to improve their insurance company performance. And you can see deductibles are rising faster than premiums. We're going to talk more about that later. And all of that is both of those are outstripping earnings. So if you have cancer in the United States, going back to the cost and effects on individuals, there's 17 million cancer survivors in the US, and their average out-of-pocket spending each year is, a third higher than people without a cancer history. And 25% reported material hardship associated with cancer. 34% reported psychological impacts of the financial troubles, such as worrying about medical bills. This was a study out of the CDC in 2019. It's this, in oncology, they've actually generated a term for this. It's called financial toxicity. And when you're in oncology, in the field of cancer care, toxicity is a big word because they're using the most toxic drugs. They're prescribing the most toxic drugs in all of medicine. But now the oncologists have started using this term financial toxicity to describe the physical and psychological impacts especially psychological, that cancer, paying for cancer care has on cancer patients and their families. And it's only in the United States that you see this, that you see fundraising. People get on the GoFundMe sites to fund all the costs associated with cancer. So anyway, so that's exclusive to the United States.